We're looking at the x-rays of a shoulder of a middle-aged male. This is his left non-dominant arm after an injury, and we're examining the fracture pattern. He has a valgus impacted fracture. You can see the displacement of the articular surface in a valgus position with the spreading and widening of his tuberosity fractures. We're also seeing what appears to be a pseudo-subluxation of the humeral head, probably secondary more to fracture impaction than there is really a true subluxation or dislocation of the shoulder, but this will need to be confirmed on other x-rays and advanced imaging. We're now looking at a CT scan in multiple planes, and I think with these type of fractures, you really need advanced imaging to be able to really discern and delineate all the fracture patterns so you can make an adequate preoperative planning. We're looking at these and we see that it truly is a valgus impacted fracture with involvement of both the greater and lesser tuberosity. The articular surface, though impacted, does not have any articular splits. It's a single fragment impacted down. So this certainly seems one that would be amendable to a surgical repair. A three-dimensional CT scan, once again, a very nice additional tool to confirm that our diagnoses are correct. These can be taken in multiple planes, and you can very nicely rotate them around to see it in multiple planes. And this confirms that we have the valgus impacted fracture, involvement of both the greater and lesser tuberosities. In this case, the rib cage was extracted, once again just showing us the pertinent bony anatomy, confirming our previously described fracture pattern. A closer view once again shows that the articular surface is impacted but is a single fragment. This nicely shows the valgus impacted and a split between a greater and lesser tuberosity with the widening of the surfaces. In our preoperative planning and setup for the operating room, we realize the positioning and ultimately visualization is critical. So the patient is usually placed into a beach chair type position, and confirmation needs to be made by moving your fluoroscope in early on so you can make sure that you have adequate visualization of your fracture in your operative field. Once again, this is confirmed with our fluoroscopic shot in an AP view, and by moving the machine around without moving the arm, you can see that we're able to get a good lateral. Confirming these positions are critical before you get started. Planning out our patient, the patient has been prepped and draped. The bony landmarks have been shown on the surface of the skin, and we'll be planning a standard deltopectoral incision. You see here going from the coracoid, extending out distally to the insertion of the deltoid tubercle. That is our standard deltopectoral incision. Going down through, we look for the deltopectoral interval, looking for the cephalic vein. This will need to be mobilized, and it's usually retracted laterally, though this is usually confirmed by looking for where the major perforators attached. As we get down deeper, blunt dissection is usually adequate to be able to get deltopectoral interval, avoiding any further damage to the soft tissues. It's extended proximally and distally, giving adequate visualization of our entire surgical field in preparation for our reduction and ultimate fixation of the fracture. We once again need to mobilize laterally under the deltoid. This can usually be done bluntly with your finger or with a periostal elevator. Retractors are placed to gently retract the deltoid, care being taken not to over-distract because of fear of injury to the axillary nerve. With retractors in place, we're able to start visualizing our fracture and the fracture fragments. Movement of the arm will allow visualization of the various fracture fragments. This is a mobile joint, and being able to rotate and reposition the arm is critical to be able to see all the fracture fragments, which will also help in your reductions. Looking deeper, we see the positioning of a retractor below the deltoid. We see the organized hematoma in the area of the fracture site, and we see a deltopectoral interval down the space between the deltoid and pectoralis insertion. In some cases, this may need to be mobilized, but in many cases, the plate can be laid right over the soft tissues in this area without any major dissection or freeing up of the insertion of these muscles. The capsule needs to be advanced anteriorly. We need to identify the biceps tendon, because this will be the guide not only for the reduction of our fracture fragments, but also for the placement of our plate. We need to, once again, identify the biceps tendon. And to be able to reduce and see the articular surface, the capsule will eventually need to be opened to give us adequate visualization. Here we see, with using sharp dissection, opening up between the interval of the greater and lesser tuberosity, which have been displaced, but we still have soft tissues laying over it, and these need to be mobilized to allow visualization of not only the fractures in the biceps, but also the articular surface. Slowly advancing in, using both a combination of sharp and blunt dissection to give visualization and mobilization of our fracture fragments. Care is taken to protect and preserve the biceps tendon. Further mobilization shows the hematoma within the fracture fragments, the displacement of the fracture fragments, and further advancement of dissection is carried proximally to expose the articular surface. Here we have the entire fracture fragment exposed. We see the exposed hematoma and the significant displacement of the fracture fragments, which will eventually need to be mobilized and reduced. Closer view, the amount of hematoma and the organization really depends on how rapidly the patient is taking this surgery. We see a fragmentation within there, which probably represents not only some fragmentation of the metaphysis, but also articular surface, which has been impacted into a valgus position. And here we see with the hematoma evacuated, we can very nicely see the impacted articular surface and the greater and lesser tuberosity fragments which have been displaced. Articular surface is inspected for further extraction of hematoma, looking for damage to the articular surface, and starting to mobilize and reduce our valgus impacted fracture. Sutures will be used not only for the reduction and traction, but also ultimately for the repair of our tuberosity of fragments. Sutures are passed and used to retract the lesser tuberosity in the biceps tendon, and now we're able to, by using a paralysis elevator, to start reducing the articular segment out of the valgus into a more normal position, period. Further retraction, further reduction of the articular surface is obtained, and ultimately the articular surface is brought up to its normal level in relationship to the tuberosities, period. Further reduction is made through the fracture fragments. Commonly the metaphyseal regions are reduced back in place, and the greater and lesser tuberosities are eventually mobilized back over the articular segment. Here we see that the articular surface has been brought up to what appears to be a normal level, but this needs to be confirmed by bringing your tuberosities back around to confirm the appropriate height has been obtained and maintained. We see here by overlaying the CT, a reconstruction of the CT, we can see that what we're doing with raising the articular surface and comparing our reduction by comparing the level of the tuberosities. And we see here we now have the reduction of articular surface, and we're confirming that by further reducing tuberosities around the articular segment. In cases of severe comminution, prior to bringing the tuberosities around, bone grafting may be needed, but in a case such as this, where all the fragments are there, there's not major impaction, bone graft may not be indicated or necessary. Looking at pictures during surgery, we see the tuberosities are being brought around, and we see that they're matching up nicely to the level of the articular segment. We're now ready to start reducing our tuberosities. These will be reduced and stabilized by using large non-absorbable sutures, which are placed through both the greater and lesser tuberosities. Usually multiple sutures are necessary to get adequate stabilization and reduction of these fracture fragments. Sutures are passed once again through the greater then the lesser. And we see as we consecutively tighten them up, the tuberosities will slowly pull together and they should reduce anatomically. So suture is tightened, and once again we see very nicely the tuberosities reducing, and we can also at this point inspect the rotator cuff to make sure that there's no major defects in the rotator cuff, which at this time will need to be repaired if they are present. Suture is finally tied, and here we see passing a second suture. Second suture is almost always necessary, and occasionally a third suture may be necessary also to get adequate stabilization and reduction of these fragments. And the tying down of the second suture shows a very nice repair of our tuberosity fractures and a nice stabilization of our rotator cuff. Once again showing our reduction and stabilization of the tuberosity fragments, which we can see clinically, and this also at this point now needs to be confirmed radiographically in multiple planes to confirm that the tuberosity has not only been reduced, but the articular surface has been reduced to the appropriate level in comparison to the level of the tuberosities. On our AP view, we see a nice reduction. The arm is rotated in multiple views, and in the lateral view, once again, we see articular surface has been reduced to appropriate level, and the tuberosities have been also reduced. Since we've used suture fixation thus far, you don't see any internal fixation on these films yet. It's good to check in multiple planes because sometimes in a single plane it looks good. You want to check your medial, make sure that not only your articular surface is reduced, tuberosity reduced, but also that you've restored your medial buttress, because this is the time to make those corrections now before you start putting in your definitive fixation. We once again see it's been confirmed lateral view, and the medial buttress has been restored. Going back clinically now, since we have we know we have our reduction and we have our temporary fixation of tuberosities, we're now preparing to do our definitive fixation with plates and screws. There was some comminution in the metaphyseal region, and this is now being further reduced prior to placing the plate. Plate is chosen. We know that these plates are designed to be positioned just posterior to the biceps tendon, and you want to make sure that position is an appropriate level superior and inferiorly. These plates were designed to, when you have the external jig on it, that's a small hole in the top using a K-wire through that hole, positioning the plate in the right place so we get adequate fixation proximally, but not have it so high that we're going to get into impingement into the chromium. Plate position is checked clinically, and temporary stabilization of the plate is done with a K-wire. And at this point, X-ray is used to confirm position of the plate on multiple views, and also to make sure that your plate is not either too high or too low. So with the plate positioned confirmed, both clinically and radiographically, we're now prepared to start putting our locking screws in proximally. Proximal fixation is obtained first, putting multiple screws into the head segment, and eventually we will then fix the head segment down to the shaft. The locking screws are drilled using the guide, measured, and the appropriate length of the screw is inserted, care being taken to make the screw as long as possible because the best bite will be in the subchondral bone. We also need to confirm that the screws are not too long for penetrating the articular surface. Length of screws are checked periodically to make sure that you do have the appropriate length, and screws are changed if you find the screw is either too long or too short radiographically. Screws are placed in serially, once again, making sure the screws are appropriate length, getting adequate fixation. The number of screws really depends on the level of the fracture, but you'd like to get at least 5 locking screws into the proximal segment, if at all possible. Multiple radiographic films are obtained intraoperatively to confirm reduction, fixation, and screw length. And once we're happy with our proximal fixation, we're now ready to lock the plate to the shaft. At this point, the proximal guide is removed, and we're prepared to lock the plate to the shaft distally. At this point, you need to confirm that your plate is sitting in the appropriate position, and that you are running down the delta pectoral interval and not trapping muscle underneath, excessive muscle underneath the plate. The type of fixation into the shaft really depends on the quality of the bone and the fracture configuration. In osteoporotic bone, use of locking screws is indicated, but in young healthy bone, standard screws can also be used. Once fixation into the shaft has been achieved, the arm is checked radiographically to confirm position of the plate, reduction of the fracture, and the length of the screws. Multiple views are used by moving the X-ray machine, not the arm. And ultimately, final fixation is checked radiographically. The arm should also be checked clinically by moving the arm to make sure that you have appropriate rotation, that there's no impingement of the plate, and you have adequate fixation of all the fragments. If you've used the guide for the proximal locking screws, it is a good idea to, once again, confirm tightness of the screws after this guide has been removed. You sometimes find that the screws have not been tightened down completely with the guide in place since you cannot really observe the heads of the screws. It's important that they're fully locked within the plate to get adequate stabilization and fixation of your fracture. Further soft tissue repair through holes in the plate are indicated at this point if further stabilization is necessary. It's many times good to stabilize your tuberosity fractures, repair to the plate, which gives you your greatest fixation and stabilization of these soft tissue components of your fracture. At this point, you want to further inspect the rotator cuff to make sure that it's been adequately repaired. There's many times a longitudinal rent that extends up through your prior tuberosity fracture, extending up into the rotator cuff. This should be repaired at this time. To further take the pressure off the plate, further suture anchors can be placed through the plate in a tension band type technique into the rotator cuff, which further protects your repair. Once fixation is complete, thorough irrigation of the wound is indicated and a multi-layer closure is performed. We're now inspecting our final results with postoperative x-rays showing that our fracture has been reduced in an anatomic position, articular surface in its appropriate position, tuberosities have been brought around and reduced anatomically. We see that the tuberosities and articular surface are appropriate height, and we have excellent fixation and reduction of the head fragment to the shaft, and all screws are of appropriate length and fixation into the bone. Clinically, at 13 weeks, we see that the patient is working in therapy, making steady progress with his motion, though full motion has not been restored. This is still early on, and a patient can anticipate a fairly long recovery with extensive physical therapy, but ultimately a good functional range of motion and function it should be achieved with this type of fracture reduction and fixation.